Hello and welcome to this online lecture on seizures. The topics we'll be going through in this presentation will include an introduction to seizures and epilepsy, the different causes of seizures, the many different types of seizures that can occur, the 3 stages of a seizure, and seizure management. A seizure is a brief alteration in behavior or consciousness as a result of disturbances in the electrical activity of the brain. There is an estimated 300,000 first-time seizures each year occurring in the United States alone. It's a very common disorder that paramedics are faced with daily, and it's important to understand the different types of seizures that can occur and how we can manage them effectively in the pre-hospital setting. There are 2 major divisions or categories of seizures. The one is called a partial seizure and the other is generalized seizure. A partial seizure is a seizure which occurs in a focal or individual point of the brain. So it's just one part of the brain is having this abnormal electrical discharge. Whereas in generalized seizures, the electrical disturbances is happening on both hemispheres of the brain. Here we have a picture of a normal EEG, or what's called an electroencephalogram. This is a test that detects electrical activity in the brain using small flat metal discs which are attached to the scalp of the patient. During normal functioning, the EEG looks quite regular in its movements that we can see over here. Whereas in a partial seizure, where you have a focused part of the brain having irregular electrical discharge, you can see that parts of the EEG are showing quite erratic electrical movement in a specific area. Whereas with the generalized seizure, the EEG has global or diffuse electrical disturbances, and that's just showing that there is irregular electrical activity occurring over the whole of the brain. Epilepsy is a chronic condition which manifests in seizures. It's a major contributor to seizure statistics worldwide. There's approximately 13,000 newly diagnosed epileptics each year in Australia. It is estimated that there are over 200,000 Australians living with epilepsy. This equates to 1 in every 96 people in Australia. These are quite high and significant statistics that reflect how common epilepsy is. Here we have a diagram showing the different classifications of seizures. We've mentioned already that the 2 major categories are focal seizures, and that's seizure activity that begins and mainly focuses in one part of the brain, versus generalized seizures that involves both hemispheres of the brain and a more global disturbance. So focal seizures, or what's also known as partial seizures, are classified as simple or complex depending on the signs and symptoms that will arise. With generalized seizures, there's many more divisions to this. So when both hemispheres of the brain are being disturbed, you can get what's called an absent seizure, a tonic-clonic seizure, which is the most common condition that people think of when they think of epilepsy. It's the full body convulsions where you have muscular contraction and relaxation. You get myoclonic, clonic, tonic, and atonic seizures. For the purposes of this presentation, we're mainly going to be discussing the focal seizures, and then within generalized, we'll have a look at absent seizures, the tonic-clonic, and the atonic seizures. There are many different causes of seizures. The brain is a very sensitive organ. When there are any alterations in blood pH, blood glucose levels, in specific nutrients or oxygen levels or carbon dioxide levels in the brain, it can get irritable, and this can result in electrical disturbances such as seizures. One of the most common causes of seizures is that chronic condition that we've spoken about, epilepsy. Seizures can be caused by fever and infections. This usually occurs in children in the form of febrile seizures. This occurs more commonly in children due to their inability to regulate their body temperature as effectively as an adult can. Head injuries or any injury to the brain, congenital brain abnormalities, physical and mental disability. So it's very common in patients who have got Down syndrome or autism to have associated seizures or epilepsy with it. Patients that may have experienced a stroke are more prone to having a seizure. Brain tumors, hypoxia, when the brain and the whole body is not receiving the appropriate amounts of oxygen, diabetes, specifically here when patients are hypoglycemic, so not enough sugar in the bloodstream, electrolyte imbalances, hypothermia, hypertensive crisis, when blood pressures are excessively high, eclampsia in pregnancy, which is also related to hypertension, alcohol and drug abuse, and in particular drug withdrawals. Observing the different types of causes of seizures, we can see that there are a number of causes here that are manageable and are treatable. So when we're discussing how to manage a seizure in the pre-hospital setting, we also need to be aware of any reversible causes or any treatable causes that we can assist with. Using an example, if a patient is maybe hypoxic and that has been the cause of them having a seizure, by opening that patient's airway, by managing their airway and their ventilations and providing oxygen, reversing the causes of that hypoxia, and in turn this will stop any further occurrence of those seizures. One of the categories of seizures we've mentioned already is the focal or other known as partial seizure. About 60% of all people with epilepsy have focal or partial seizures. These seizures can often be subtle or unusual, and they may go unnoticed or be mistaken as something such as intoxication or a mental disability. Seizure activity arises from an identifiable lesion inside the brain. A brain lesion refers to any type of abnormal tissue on the brain. Examples of this can be tissue that has undergone traumatic injury or been altered due to severe infections. It can also be a result of vascular abnormalities or genetic abnormalities, to name a few. There are two types of partial or focal seizures. The first is called a simple partial seizure, and the other is a complex partial seizure. A simple or partial seizure may originate either in the motor or sensory cortex. It can result in a jerking or twitching movement, so clonic movement, in one body part or body region. It can result in altered sensations and visual, auditory, olfactory, or taste sensations. And in focal or partial seizures, the patient usually remains conscious and they're aware of what is happening the whole time. So if you ask a patient after they've just had a focal or partial seizure, did they know what was happening? They'll be able to describe everything that they saw or tasted or heard or felt during the time that they were having that seizure. Partial seizures also have the ability to progress from one area of origin and spread in an orderly way to another area. It's called a Jacksonian seizure or a Jacksonian march. Complex partial seizures are very similar to simple partial seizures. However, they usually arise from areas such as the temporal lobe, which manifest in changes in a person's behavior. An example of this would be an abnormal repetitive behavior such as lip smacking or chewing their gums or swallowing repetitively. Patients often do not remember these types of seizures, so slightly different to those of partial. They're short-lasting, usually less than 1 minute, and once they're completed, the patient returns back to normal status rapidly. Here we have a video of a child who's having a complex partial seizure. They are quite difficult to pick up because they're so subtle.
Seizure. Your right leg shaking.
It's so cut out. No, it's showing I can see the back. No, I can see.
In this patient, the signs and symptoms included a rigidity or a stiffness in that left arm. The child was also having some mild shaking and jerking movement in the right leg, and then some repetitive facial twitching, so twitching above the eye over there. But you would have noticed that the child was still able to look around and seemed to be quite aware of her surroundings. When the mother or the carer knelt down on the floor next to the child turned and looked at them. So it just goes to show that not the whole of the brain is affected. They're still able to process certain bits of information while the seizure is occurring, and the child was very aware of when the seizure had actually ended. In comparison to partial or focal seizures, generalized seizures involve both hemispheres of the brain simultaneously, and they can result in many different types of seizures. We're going to be having a look at the absent seizure, the tonic-clonic seizure, the myoclonic, and the atonic seizure. The absent seizure was previously called a petit mal seizure. It's a brief and repetitive non-convulsant event, so we don't have that whole body shaking and jerking occurring. It usually occurs in the young and it involves the whole brain. The person's awareness and responsiveness may be impaired. Signs and symptoms can involve staring, eyes rolling back, or eyelid flutters, and in some cases there may be a mild or discrete hand movement. Absent seizures start suddenly and they cannot be interrupted. They only last a few seconds. The person will be unaware of it occurring and they will continue on with the activity that they were previously doing. Although these seizures are very short, they can occur many times a day, and this is what can be particularly disruptive to learning. Absent seizures are often undiagnosed, as parents and caregivers may think that the child is daydreaming or simply not paying attention. We have another video here to show you what an absent seizure can look like. Pay special attention to how the child doesn't seem to notice that he's actually had a seizure and continues on with his activities.
1, 2, 3, 4, 5, 6, 7, 8, 9.
The other way it showed you it didn't. There was a plus. Miguel.
Huh?
What's the plus sign? You need to put the plus sign.
Even though you're absent, she sent me the homework that when I was absent.
Do you know what it did, Miguel? Miguelito. Okay, so what are you supposed to do today?
Atonic seizures are generalized seizures that affect the muscle tone. They result in a sudden loss of muscle tone in the body, which results in a person collapsing to the ground. The person usually remains conscious during this episode. It's often called a drop attack or an astatic seizure. These seizures usually result in some kind of head or facial injury due to the rapid fall to the ground and the patient being unable to brace themselves with their arms. The myoclonic seizures are characterized by a brief shock-like jerk in the muscle or muscle groups. It usually lasts no more than 1 or 2 seconds. There may only be just one, but sometimes many will occur within a short period of time. It very rarely results in an injury, and the person usually remains conscious during the process. Tonic-Clonic seizures were previously called grand mal seizures, and they are commonly associated with significant morbidity and mortality. The seizure itself is characterized by the body stiffening and the patient rapidly losing consciousness so that they then fall to the ground, and this is called the tonic phase. This is followed very rapidly by the clonic phase, which involves alternating contraction and relaxation of the muscles, jerking the limbs in a symmetrical rhythmic movement. This is that classic convulsion that people associate with seizures. During the process, the patient may bite their tongue or their cheeks. There may be some bloody saliva secretions from the mouth. The patient also may be drooling from the mouth due to the inability to swallow during the seizure. The patient can also appear blue or red in the face, and there's a high probability of urination or defecation due to the loss of bladder and bowel control. The tonic-clonic seizure generally lasts for 1 to 3 minutes. And unless an individual epilepsy care plan states otherwise, families and friends are advised to follow the general guidelines that if somebody experiences a tonic-clonic seizure for more than 5 minutes, call for an ambulance. Seizures that last more than 30 minutes or a series of seizures in which the patient didn't regain consciousness in between indicate a dangerous condition called status epilepticus. Without immediate management, this can result in permanent neurological damage, respiratory failure, and death. Associated complications of status epilepticus include aspiration, brain damage, and fracture of long bones. So it's very important to note that when you come across a patient who has been experiencing seizures, ask the bystanders how long the patient seems to have been fitting for and if they have regained consciousness in between seizures. This is a video to show you what a tonic-clonic seizure can look like. It's coming down.
Yeah, this is 40 seconds. So it took me about a minute.
Do you say add a minute?
For sure.
Okay, Jakey.
There we go.
Each person's degree of intensity in the tonic-clonic seizure can vary. This child had quite a mild seizure. A lot of people can have incredibly violent seizures where their arms and legs are thrashing around and they're hitting their head into the ground really hard. So just remember, one of the first things we do, like we're taught in first aid, is to actually protect the person from hitting their head on the ground and protect their limbs to prevent any further injury. There are 3 stages that occur in a tonic-clonic seizure, and some of these stages can occur in varying degrees within other types of seizures. These 3 stages include the aura, the ictus phase, in which we have the tonic and the clonic phase, and then the post-ictal phase. Starting with the aura phase, the aura typically happens a few seconds before a seizure occurs, and this can act as an alert for somebody that a seizure is imminent. Often this can help somebody to get themselves onto the ground so that they don't fall over and hurt themselves, pull over in traffic, or notify a family member or a friend that they're about to have a seizure. The symptoms that accompany an aura can vary greatly depending on the type of seizure that occurs and which part of the brain is affected. And this can also vary quite dramatically from person to person. It doesn't seem that there is any 2 people that have the same or similar type of aura before they have their seizure. Signs and symptoms of an aura include things such as unusual feelings or abnormal sensations, such as a déjà vu, which means familiar feeling, or a jamais vu, meaning an unfamiliar feeling or something they've never experienced before. There can be strange sounds, tastes, or smells that the person is experiencing. So some people might get a visual disturbance, see something that isn't there, or they'll smell something that's not there, or taste something that's not there. Some people have reported smelling burning rubber, for example, when there wasn't actually any burning rubber in the area. Other patients may have physical sensations such as dizziness, headache, numbness, and lightheadedness or nausea, and others may experience distorted emotions such as panic or fear just before the seizure occurs. This phase usually only lasts a few seconds, and it indicates that the seizure is imminent. The ictus phase comprises of that tonic phase, where the patient's body becomes rigid, they quickly lose consciousness and fall to the ground. and the clonic phase, where you have that rhythmic contraction and relaxation of the muscles, which is known as the convulsion. The post-ictal phase happens immediately after the active tonic-clonic phase, so once the convulsion has actually stopped. There can be varying degrees of neurological deficit, and this can also vary in length of time from person to person. Signs and symptoms can include a low level of consciousness or the patient remaining unresponsive for a while. The patient may be confused or agitated, anxious or aggressive. The patient will be very fatigued and drowsy due to the massive exertion that is undergone during the seizure, and they may be complaining of a headache. This is the last video of our presentation. This shows a young man who has just had a seizure, who is now in the post-ictal phase, and his partner is recording it.
Hi, baby. Okay. Okay. Keep this around. I don't need to pee on the bed. You're okay. You're okay. It's okay. It's okay. I need your bucket. This is really weird. It's okay. Do you need a bucket? No? You okay?
This video really depicts the different signs and symptoms that can be seen in the post-ictal phase quite well. There was a massive alteration in the patient's level of consciousness, lots of blood and oral secretions coming from the mouth. The patient was very confused and a bit combative, throwing things aside and having slightly aggressive movement in his body language. Even when somebody he knew was trying to communicate with him, he wasn't responsive back to them and was very, very tired and fatigued. And you could see at one point he was actually starting to fall asleep. When it comes to managing patients in the post-ictal phase, never try and restrain them or aggravate the situation. These signs and symptoms will resolve. Our biggest concern here is just ensuring that the airway is clear and that the patient does not harm themselves any further. And having a look at the overall management of the patient experiencing seizures, we'll conduct our systematic approach and do our DRS ABCD. Never try to restrain the patient or place anything within the patient's mouth. Ensure that you move any obstacles away from them and protect the head and the limbs from injury. Observe the type of seizure that's occurring, how many seizures have occurred, and how long they are occurring for. Obtain a sample history of this patient. If they're known to have epilepsy, ask about the medications that they're on, if they've taken their medications that day, and if they've had any alcohol or drug consumption, as this can alter how the medication works. After the seizure, try to put the patient into the recovery position and monitor them closely. Check the airway and suction if necessary. Assess respirations and circulation. Provide O2 therapy. This can also be quite a difficult thing to do, as you've just seen that post-ictal phase, the patient could be rather combative and quite aggressive in their behavior. So even if you can just hold the O2 therapy mask quite close to the face, you don't necessarily have to have it on their head until they're a bit more willing to accept it. Conduct your secondary assessment and a full set of vitals. Look for any reversible causes of the seizure. This could include something such as hypoxia. If a patient has had a seizure because they have been hypoxic and not getting enough oxygen to their brain, by supplying oxygen therapy to them, we can then reverse the cause of that seizure. Or an example, if a patient is suffering from a febrile seizure because their temperatures are too high, we can actively cool the patient down to prevent any further seizures from occurring. Documentation is very important. We need to document how many seizures occurred, what type of seizure occurred, and how long they occurred for, so timing them. Make sure that we calm and reassure the patient, as during the post-ictal state they can, as we've seen, be quite combative and confused and restless and agitated. Use nice, soft, soothing tones when talking to the patient. Never try and force them or restrain them into anything, but calmly speak to them and keep them quite calm, and transport to hospital as soon as possible. This concludes the presentation on seizures. If you have any further questions, please don't hesitate to contact us.